Okay, are you ready if I just go? Yeah. So we're just gonna do pediatric trauma and airway. The number one thing when it comes to pediatric patients is managing the airway. If you can manage their airway, things are gonna go okay. It doesn't matter if it's a broncholytic or if it's a trauma or if it's just, some medical kid, a septic kid. If you can manage their airway, you can do everything, you know what I mean? Truly, that's the number one thing. I learned, I've been doing this for a really long time. I've been flying for 12 years, and I worked in the PICU for 22 total up at Primary Children's. So I do kids, right? I don't like to go hang out with the adult people so much because most adults stink, and I do hang out with the neo people because little babies are amazing too. So
so are the nurses.
So I feel pretty strong that kids aren't just little adults, and I feel like you can always learn, and I learn from experiences. You can listen to PowerPoints, but when something happens to you and you'll think, I'll never forget, that DKA, the first kid that has bad DKA that rolls in, will you ever forget what they look like? No. And so I do, so I'm gonna share some of my experiences with you, and hopefully we can just learn some, and I've got some great visuals that will help you so that you will never forget. So pediatric trauma, when we talk pediatric trauma, you can go ahead and turn it. So they have the same things happen to kids that happen to adults, right? They fall, hit by car accidents, same kind of things that happen to adults. The thing that's different from kids is that, so you get hit by a car, right? So if you're an adult who gets hit by a car, you're gonna have more leg injuries or pelvic injuries. Kids, their head is the level of the bumper, so you're gonna have mostly head injuries, right? With that kind of, typically. Falls, right? They have big fat heads, sometimes depends on the age of the kid. Head injuries are still number one. Drowning, I think we see, there've been a lot of adult drownings lately, but pediatric drownings, typically we get them back, right? Because their hearts are pretty good. If you manage the airway, you're gonna get their heart rate back. You will. If you don't manage their airway, you won't. Prime example, they had a kid that came into Intermountain the other day, and the kid was, 4 or 5 months old, full arrest from home, esophagically intubated, wrong size tube, right main stem. They never got a heart rate back. But I guarantee you, if they would have intubated him initially not in the esophagus, if it hadn't been right main stem, if they would have put the right size tube in, they would have got a heart rate back. Would the kid have survived? Probably not. But I'm a huge proponent of organ donation. This is something I'm going to show at the end of my presentation. So for you guys, sometimes you probably think, why did we transport that kid? Why, right? This kid is not going to survive. I'm going to show you something pretty cool. So managing the airway is the most important thing I think you can do. So let's go ahead and secondary injury. So we cannot change the fact that kids get hurt or that they're sick or even though they have bronchiolitis. We can't change that. So the one thing that we can do is prevent secondary injury. Anybody know how you prevent secondary injury? And what is secondary injury? This is where you guys talk.
Barrel trauma, is that what you're thinking about?
So I'm gonna tell you a story first then, so you'll remember. So secondary injury, right? We can't change what happens first. So when I think of secondary, this little girl will never go out of my head, okay? So she was like, I think 7, 8, sledding with family, and they were up in the mountains and they had snowmobiles. And so they were coming down the hill and the family would drive them back up with the snowmobile so they didn't have to walk back up the hill. And so this little girl came down and ran into a snowmobile. So she has an obvious head injury, right? She's sort of unresponsive. I wasn't there, so I'm just kind of guessing how things looked. You know what I mean? So in the middle of nowhere, but she's breathing, right? And so what does everybody think? She's breathing, it's okay, we're just gonna get her to a hospital. So she had agonal respirations. So they call 911, takes EMS a long time to get there, and I don't know if they met at some point. She was taken to a referral hospital, was never intubated, never bagged, agonal respirations. So her initial scans showed a survivable head injury, pretty significant, but something that you probably would survive. She was a donor because of an anoxic brain injury. So that's what I mean, secondary injury, right? We can't change the fact that she ran into that, but if we would have been there opened her airway better, bagged her, assisted her, kept her from being hypoxic, she probably would have survived that. So our goal is to be on our A game, right, and prevent secondary injury. So that's what I mean, right? We can't change. one of the most important things that I sort of think is pretty important is knowing what's normal, right? So normal vital signs for an adult, right? You want a blood pressure of 120/80, a heart rate less than 100, it's all the same. And so with kids, it's so different. And so if you don't know what's normal, it's easy to say, I don't think they look too bad, right? It's okay. So I have vital sign cards. I don't know if you guys have these or not.
We do.
Okay, so if you don't have them, I'm gonna set them here, pass them around. So this just tells you what's normal, okay? So just what's normal so you can recognize what's normal. So it's really important to know what's normal, what's not normal. And then if you know it's not normal, what are you gonna do about it? Don't sit on your hands. And sometimes I feel like as nurses, sometimes you kind of have to, tell the doc, I don't know that I feel good about this. These guys recognize that we've been around the block, and they recognize our expertise a bit, but you need to make sure you tell them what's going on and do really good assessments. So let's go ahead. I've got some differences between peds and adults. So number one, I feel like is the airway, and we're gonna expound on that in just a few minutes. Everything's based on weight, which if you're not used to it, it's kind of stressful. But you guys have brow, they have some cool tools out there now. The hand Tevi, the Braslow, there's a lot of cool tools to help you do what's right. Their bones are less dense. So if you have a kid that's 6 months old that comes in with a rib fracture because they fell off the couch, can you fracture a rib falling off the couch? No, you can't. You cannot. And so it takes a lot of force to get a rib fracture, okay? So just know that if they have bone fractures, typically they hit it pretty hard to break their bones. Their vitals aren't the same, we already talked about that. And they can compensate for a lot longer than adults, okay? And this is where I feel like the assessment is huge. Paying close attention to your assessment and letting the physicians know. So just a prime example, the kid that we went on that scene yesterday was a little 5-week-old bronchiolitic, right? He was sitting at this freestanding ER, a little clinic ER, for hours, had been there for hours, and they were trying to send him home. He needed oxygen, but then he didn't need oxygen after they suctioned in. But I don't think anybody ever really did a good assessment. And so when I talk about assessment, what am I talking about? When you assess a little person, what are some things that you're looking at?
They're breathing.
Okay, are they retracting? Right, what else?
Heart rate. Counting a
Heart rate.
Too.
Yeah, respiratory rate. What is color? I love it. How about, so this little dude modeled to beat the band, right? So, I don't know, what did you say? He looked like, he was purple. I couldn't get a blood pressure on his lower extremities because he had a weak pulse. It wouldn't read, okay? So in my mind, initially, I'm thinking maybe he's a coarc or 5-week-old, his duct is shut, I could get a blood pressure on his uppers, but not on his lowers initially. So perfusion, and he's cold. His extremities are cold. So if his extremities are cold and he has a fever, we all kind of poo-poo it, right? It just kind of, he's got a fever. Is it really cold? So something to kind of reevaluate. So our shock protocol that we follow for the whole following, sepsis protocol stuff, if their heart rate's up, if they have a fever, if they're breathing fast, perfusion is huge, right? It ranks up there. So if they're modeled and they're cold and they have poor pulses, that gives them like 2 or 3 points, right? Right then they've met shock protocol. I can tell by looking at this guy, I didn't even have to put my finger on him, that he met shock protocol. Okay, so perfusion is huge. So this kid sat there, and I don't know how much people put their hands on him because he didn't look horrible. And he was a kid that wasn't like laboring to breathe, he just wasn't breathing great, right? Just kind of shallow and fast. And so they were getting ready to send him home, and then all of a sudden, he braided to 70 and dropped his sats to 70, like as they're sending him home, okay? So that's what I mean, they compensate, they fool you. And so you really have to put your hands on him and assess him, yeah, his vitals are sort of okay, you know what I mean? They don't look bad, we're gonna send him home, right? So you really have to put your hands on him. Like I said, I dare say if they'd have really examined him, he probably wasn't okay. And so the kids do that to us all the time, they're kind of naughty. They have big heads compared to their body surface area. So like I said, falls are gonna dink their heads more, shaken babies, you know what I mean, it's gonna get their head. You get hit by a car and your head is right there at the bumper. And so head injury, I would say, is probably the #1 significant trauma that we see with kids. And Seatbelt injuries. So I actually got pulled over the other day. I had my grandkids, and my one little grandson is almost 6, and I didn't have a booster seat, so I just had him in the back seat. I was just going down the street, but not in a booster seat, and I got pulled over. And there's a reason for it, you know what I mean? And I didn't want to say, oh, I'm a flight nurse. I'm not just a flight nurse, I'm a pediatric flight nurse. How embarrassing is that? I didn't say that, I kept that on the down low. But seatbelt injuries are caused, I mean, because they don't have the musculature and the extra fat that we all have. And so seatbelt injuries are pretty common. So they might look great, but if you have a positive seatbelt sign, you know what I mean, you should probably pay attention to what's going on there. So sclero, anybody know what that is?
Spinal cord injury without radiographic.
Right. And so this is one of those things, the kid we did yesterday, one of the kids, he had no spinal fractures whatsoever, was unable to move or feel anything below the waist, right? Fell off of a cliff thing that he was hiking, fell off. So, you know, that's one of those things that happens with kids. And so, because their bones are soft, a lot of times they don't break a bone, right? And you'll see, I think the time that you see it the most, right, is when their head slips, comes back, there's no fracture, that they're symptomatic. So let's go ahead.
Sorry, I didn't hear the RA.
The what?
Radiographic
Radiographic abnormalities. So you can go ahead. So one of the big things that happens to me all the time, and I feel like people hate me, is I'm gonna come to your ER, your docs have done all the imaging, there's no fractures, and they took the collar off, right? Because it pisses off the baby anyway, right? No one wants a collar. And I come in and I have to put it back on. And it's so hard, okay? So to get cleared at Primary Children's, the reason that it might not, it doesn't, click it, I think it has a couple more things that pop up, yeah. So things that they cannot be cleared is if they have a distracting injury, if they've had any sedation meds, or if they have an altered mental status. And so I'm here to say that a lot of kids, right, who've been involved in some sort of trauma have a broken arm, broken leg, right? You have a distracting injury, so I can't clear it. And so they have to go to primaries, they have to have a FlexX with a neurosurgeon, right? That's how they clear them. And so if I show up to Primary Children's without the collar in place, I'm not even kidding you, I've done it more than once. I try to think, it doesn't make any sense, and I have lost butt cheeks, like, you get chewed, it's not, you know what I mean? So I put them back on, and that's why we put them back on. And like I said, they don't make us do this to be mean to the kids. They've obviously found several kids who've had significant spinal cord injuries that had, you know what I mean, that were cleared, if you will, at a referral hospital. So that's why we have to put them back on. Very unfortunate. And so it's easier if you guys keep them on, but if you need me to be the bad guy, I will take one for the team, because I do like, I hate to be chewed out. It's really, it's hard, you know, it's hard. So let's talk airways. Are we ready to play with some stuff? Pediatric airways are different. So the big thing, if you look at the picture up there, the cricoid cartilage is below the vocal cords that you see, and that's the narrowest part until they're 8 years old of a pediatric airway. We used to, right, use uncuffed tubes all the time. We used to tell you, don't use a cuffed tube. Anybody know if that's true or not anymore?
Are they going away from it now?
Yes, it's very, very false. If you came in and you were a 28-day-old that's going to the PICU, I would intubate you with a 3.0 cuff tube, maybe even a 3.5 cuff tube, right? So cuff tubes, and I'm going to show you why. So what is an air leak? Let's start with that. What is an air leak? So if you have an intubated patient, what does an air leak, what is it?
You're not getting enough volume in because the air's leaking out.
Somewhere.
Perfect, right. So you have a huge leak around your tube, right? And so when you give a breath, especially, and the sickest patients are gonna be the worst, right? So if you have a really, really sick patient and you put too small of a tube in and your air leak is huge, those are the ones that are gonna be the worst, right? The scariest, you know what I mean? The biggest problem. So I feel like a lot of times when you're bagging patients, let's see if I can get this one down. When you're bagging patients with this big old thing and it kind of honks a little bit, right? It's really hard to hear if you have an air leak. I mean, anybody agree with that? So what does it look like? I know what it is, and we can hear it maybe, but what does it physically look like? What are some things about your patient that can say, this kid has a big air leak?
Well, you wouldn't get enough lung expansion.
So chest rise, perfect, perfect. What else? I'm a more visual girl.
Sats, color.
SATs are, right? something even more visual than that. It's basic. Have you ever seen some patient that blows bubbles out of their mouth with every breath, right? Happens all the time. Big air leak, right? Big air leak. And so, doesn't matter, you know, doesn't matter if you have air leak. So adult patients, you put in the same size tube, right? A 6 to a 7, and you fill it up, the balloon with 10 cc's. That's what you do. So on a pediatric patient, right, we used to tell you not to use a cuff tube, use uncuffed tubes, and so it doesn't matter. So I have this as a pig lung, and so this pig lung is probably bigger than an adult. So I have a 7.0 tube here, and I just didn't inflate the cuff, okay? So it's in the airway.
Push the pad on over, please.
Oh, is it? You can't see it.
Thank you.
So essentially I've given this adult patient an air leak, okay? That's fine. So does it matter, are we gonna inflate them or not? So let's just see. Okay, so let's get rid of the air leak. So how much do you inflate your adult cuffs with? 10?
10.
So this is a big old one. I can't even tell you how many times I've come into a place and really, this is no Peep, this is Jimmy, that's just the air leak. And so, I mean, this lungs, they're pretty sick, right? They've been dead. But if you have a really sick patient, you know what I mean, you're not gonna move their lungs. And I can't even tell you how many times I've come in someplace and they've intubated this 6-month-old with a 3.0 tube. And they said that's all they could get in, but then they have this huge air leak, and I can't, and so I'm gonna have to re-intubate them. And everyone gets their feathers ruffled, like, but can you see it? This doesn't work, right? This doesn't work. So there's some things that we try. We try to do a pressure mode of ventilation versus a volume mode. Sometimes we can prevent, I mean, because we all recognize intubation, right, is a scary procedure, doesn't always go perfect. You know, when it goes perfect, I'm always so happy, like, oh, best day ever, right? But it doesn't always go perfect. No matter what you do, it doesn't always go perfect. So an air leak is a huge big deal. My ventilator won't run sometimes if the leak is too big. So is it a big deal to re-intubate? Let's talk about how we would do that. Have you ever seen them do a tube exchange? Have you ever seen them? And so I actually personally, now that we have video scopes, I think it's awesome. You just put the video in, you see the tube, you have the second tube ready to go. And so I'll have it ready to roll. I'll tell Jan to pull the tube. She'll pull the tube. I'll put the new one in, and it's slick as a whistle, right? They shouldn't even decompensate much. But you can see that this doesn't work, right? That's not effective. So air leaks are a huge big deal. So the right size tube is sort of important. How do you know what size tube? Braswell will tell you, right? I actually brought a few of these, Jen, and I don't know if you have any of these. These are the last ones I have. We've ordered more. They're a vital sign card with a drug card on it. And I actually think it's a Braswell on a card. So if you look at the back side, the thing that I think is most valuable about is the back side. You can flip it on the back, close it on the back. So that right there will tell you what size tube to put in, how deep to put it, and it has emergency drugs on it. So I carry one of those in my pocket, and then I actually have tape cut to secure my tubes in my pocket, in my flight pants. So how do you guys secure your tubes on these pediatric patients when you intubate a patient? Do you guys have tube holders? Do you use tape? What do you guys use?
Well, the docs tend to just grab the twill tape, but like we know that flight or primaries prefers H tape, so we try
Right.
to have that available.
Right, right.
Because we know when you get there, you're gonna take that twill off.
Well, they make us.
I know, yeah.
I know. So I know you guys think sometimes that we are
No, never.
the
We
PC is
get
a
it.
pain in the ass. but they make us, right? You know, and you extubate somebody in transport. Do you know the paperwork involved in that? Guys? Like, can't even tell you. Actually, knock on wood right now. I've never done it. Never done it. But there's a lot of paperwork involved, and so you can actually almost pick up a patient if you have an H tape and you've got it taped good. You can almost pick their head up, and you won't extubate them. It's pretty secure. So twill tape, all it takes is goobers, and it slips, right? And adults, they have a lot more room to slip, right? So if I slip a tube at half a centimeter, I could extubate a patient. And adults, it's probably gonna be okay, right? So that's the big difference, and that's why they make us do that. So you guys know the H method and feel comfortable
I think
cutting it?
everybody does. Like, I know I do because of flight, but I don't think everyone, especially who would
I don't
watch
have
movies.
tape on me. So maybe for the next class, so essentially, and the newborn team still does it different, and it is what it is. They do a Y method, so we're not even the same. But the H is, so you take a piece of tape and you cut it, do you know what I mean, from both ends, so it's only connected right at the middle. So essentially you have an H, if you will. You put the top layer on their lip, and then now you have two pieces, you wrap around the tube each direction, okay? So you can wrap it all the way. I like to wrap it once or twice and then go back opposite of the way it came on both sides, and then put a mustache, we call them, over the top. So just know that I don't always retape it. If it looks pretty secure and I think I'm gonna ruffle feathers, I won't. But the docs at primaries sort of expect us to do that, so is what it is.
Like, I agree, I've seen where it's more secure. Like, I wish it worked for adults because it is so secure, you know. But
Well, and a lot of people have these things, these tube holders. I don't know if you've ever seen the tube holders that people have. Those are even worse because on a little person, you can't see, and it pinches the tube. Sometimes it actually causes we're talking little airways, and you try to put one of those on a little airway, it kinks it. So those and they're really a nightmare to get off without extubating the patient. Anyway, so they're cool, but not, I mean, difficult.
yeah, the
Difficult,
thought's
I guess.
good, and execution's poor with those.
Another thing, another trick, I know probably a lot of you guys don't intubate, maybe you guys intubate babies. We have to go in, we have to have so many tubes a quarter. We don't get them, we go to the OR at primaries, we can't practice on a mannequin. So we do practice a fair amount, and we have, you know what I mean, so we do. One of the things that I learned, so you get to learn from different anesthesiologists, different different doctors all the time. One of the things that I found the most helpful on littler babies in intubating was from Dr. Knoll, who was a neonatologist at Primary Children's. And I'm just gonna give you this visual because while some of you are physicians and you probably, or do this all the time, you guys all help, and you're part of a team that's intubating patients all the time. When it comes to adults, I feel like they really crank back the airway, right? And they put them in that sniffing position times 10. And so I think that if we put a pediatric patient, because their airway's more anterior, if we put them in a more sniffing position, it's gotta be better. So I'm gonna do a visual, and I really don't wanna see this. So if an airway's more anterior, what does that mean? Anterior, right? So it's hard, up here more, so it's harder to see when you're trying to visualize with the blade. So I want you to see if your airway's that much more, the more you crank back, what does that do to your airway? It makes it more anterior, right? So you have an anterior airway that you've cranked the most. So I can sometimes tell by the way people position that they're gonna mess up. Dr. Knoll, what he told me that helped the most is especially on littler babies, right? So he actually doesn't really crank them. He puts a small, like a wash rag under their shoulders, and he actually lifts their head. So he will put a small towel or blanket under their head. So visualize that. Instead of cranking back and making that airway go more anterior, he pulls it down, and you can see, right, how that's gonna help, right? And I still remember I was intubating a little 6-week-old up in Jackson Hole, and I don't know why everyone gets all ruffled, like, they're intubating a baby in the ICU, and so the ER doc shows up, and if you want to intubate, feel free. I've done this a lot, but if you want to, but the stress level, right? I want to say, if you guys would just back off, it's okay. It's gonna be okay. But I think I probably had a room of 15 people there to watch me intubate, and the ER doc came in, and I had everything ready. I had a little roll under his head, a little roll on his shoulder. I'm all ready to go, and the doc goes. And we have a checklist. That's the other thing I'm gonna bring up right now. But I went through the checklist, and he goes, "You need a bigger roll under the shoulder." And he flips it up and does it. And you know what? I let him do it. I didn't change it. Like, I know better, right? I know that's not what I wanted. And because he's a doc, it's intimidating. Do you know what I mean? And luckily I got it the first try, and it was totally okay. But do you know what I mean? But just knowing, positioning little kids when you're intubating is so helpful. And a big roll, like I said, sometimes if I need a tube and I don't want to go to the OR, I watch them like, all right, you go for it. And if you don't get it, then I get the next shot. You know what I mean? But just know that when you're doing little babies, a big roll is not helpful. And it just visualize, all it does is crank it more anterior. So what do they do when they intubate? Watch them. What do? They pick their head up off of the counter, right? To make it so it's angled so that you can see the tube. So the next time you watch somebody intubate a kid, you know what I mean? And not all of our team does it that way. I think we're all a little bit different. I mean, what would you say, Jen? You think that's the most helpful?
Yeah.
You put a little roll under the little one's head. So the other thing I'm gonna ask if you've ever seen is the intubation checklist that we use. You guys, yes? Lifelike, you better say yeah, right? So this is something, so they do a timeout, right? You go to the OR and they're doing surgery, we do a timeout, but make sure everything works okay. So we're not perfect about doing this. I do feel like we're getting better about it, because it just really is, it's good practice. I'm not gonna do this on a scene, right? I'm not gonna say, would you read this and let me do the checklist before I intubate? I'm not gonna do that. But in the hospital, and I feel like the more you do it, the better you are and the better the process goes. So what does this look like? I'm gonna hand this to you, Kevin. So I'm gonna get everything ready. If I am on the Peds unit and I'm gonna intubate this patient, I'm gonna get everything ready and I'm gonna say, all right, let's go through the checklist. Typically, like I said, this is how I do it, and not all of us do it exactly how Lori does it. But I'm gonna give it to you, or maybe I'll give it to Jan, and I'm gonna say, okay, will you just read that off to me?
Okay, roles assigned.
Okay, so roles assigned. So what this means to me, and I think this is invaluable, and like I said, even in the ER, I think it would be invaluable to use this. So what that means is I'm gonna try twice. If I don't get the tube on the second try, then I'm gonna say, you know, Dr. Carey is gonna intubate, or Jan, I'll have Jan try twice. At that point, you know what I mean? What we have in line, do I have backup things ready? So that's what I mean by roles assigned. The other thing I'd love to do is because there's a lot of people in the room, and I like people to have a job. And so what's really helpful to me is after I do all this stuff and get going, I have to put a chart together, right? So sometimes I will say, you know, if you will just fill out a little, like a code sheet, if you will, write vital signs and the meds given and the times while I do this, and then they give it back to me. Oh, so give somebody a job to do, right? So those are some of the roles I'm gonna assign. So
And
the next one.
thing, I think, just you watch the SATs and the vital signs and let me know when this is my threshold. If I hit 90, you tell me where I'm at.
Right.
Instead of everybody out in the room just going, oh yeah, you're doing fine, you know, and everybody, if you just have one person designated to do that, that's good. Another thing is like, you're the RT, you're gonna bag as soon as I get in, just a few of the roles that you need to assign.
Perfect. And I do think sometimes when you verbalize that, and I don't know, maybe you've never seen this, but if you verbalize it, I'm trying twice, and if I don't get on the second try, somebody else is gonna have to take a look at it. You prevent that person trying 10 times to get the tube in, right? Because sometimes, I don't know, maybe you're not on your A game for some reason, maybe you're just not getting a good look. And I wish all airways looked the same like on the mannequins, but good hell, they don't. They do not look the same. No two airways are alike. So number 2, go ahead.
Number 2 is position optimized.
Okay, so I'm gonna say, yeah, I like my position, you guys, Jimmy, and that's when my physician in Jackson Hole said, no, they fixed it, and I left it. I still am pissed that I left it.
Pre-oxygenation.
Pre-oxygenation, okay. Another thing that we're gonna talk about a little bit is apnic oxygenation. So when we do the checklist, it'll be much faster than right now, just throwing that out there. So I will keep these kids on oxygen, right? Have you ever, and we want them to have stats of 100 if you can, before we try to make an attempt to intubate. So I'll leave their high flow running. If they're on BiPAP, right, you can't keep a BiPAP mask on, I'll throw a nasal cannula on. So apnic oxygenation is the fact that patients will stay oxygenated higher if you have oxygen running even when they're not breathing. So even though you give a paralytic, you'll have so much longer to look, and you will feel a little bit less stressed, right? Because nothing's more stressful when you're looking and you don't have a great view, and they say, oh, your sats are now 88, right? Like I'm gonna have to stop, or you know what I mean? It's very stressful. So it will definitely keep your sats up longer if you keep a nasal cannula running. Like I said, high flow I leave on. If they're on BiPAP, I will throw a cannula on. Put it on 6 liters until we're done. Just for a minute, it's not gonna dry out their airway.
Bag assist with Peep available.
Okay, so bag assist with Peep. And so I'm gonna dare say, make sure your bag, make sure it's connected to oxygen, okay? I'd like to think that's a no-brainer, everyone would know that. Occasionally, right? Stuff happens. So make sure you have it connected to oxygen. This one, you don't need oxygen to make it go. So if you have this at your bedside, what's your Peep?
You don't have it right now, you don't have a Peep valve.
Right, your Peep is 0. And so a lot of places, a lot of EMS agencies don't use a Peep valve, okay? So your Peep is 0 when you use this, okay, 0. So make sure you know that. Is that adequate?
No.
In my mind, never. Like, you should never use this without your PEEP valve. Somewhere under this disgusting mess. Yeah. So the PEEP valve just goes right here on the end. Different bags sometimes look a little different, but you'll see where it attaches, okay? And then you can put your PEEP where you want it. So if I were setting up a ventilator, where would I keep the PEEP at?
5 to 8.
Yeah, so 5 is like typical, like where I would just set it up, was that 5? Okay, so bag PEEP assist, we've got it ready, and it's connected to oxygen.
IV, IOP.
Right, so if you ever intubate somebody and they go to give meds and IV sucks all the time, right? So something that you should check even before you have, you know what I mean? So make sure it flushes before you have them, you know what I mean?
Suction.
Suction, turned on, ready to roll, okay?
Vitals pre-procedure.
Right, so we actually tried to do a set of vitals right as we're intubating.
ETCO2.
So Untitled CO2, so either, sometimes the newborn, well, all the time, the newborn team uses a color metrics, and we'll have one that we'll use with a Zoll. Another interesting thing that I've noticed when you're intubating little kids is the color is so much faster. If you're waiting for the end title to pop up, sometimes it takes a couple breaths and you'll have people peeing their pants, freaking out, right? And their stats are dropping and you're like, it's okay, give me a minute. So if you're intubating a little person with smaller tidal volumes, I highly recommend that you use the color metrics in addition to your waveform. I mean, if you guys all noticed that and appreciated how that, it just takes a while, you know what I mean? So it's nice to have immediate confirmation, makes you feel better immediately. Otherwise you have to wait a second and sometimes it's a little stressful.
Devices, VLDL, ETT, tape, syringe.
Okay, so tape, syringe to inflate your cuff. And so you should have some backup stuff readily available, right? So a backup, an LMA, a King Airway. What are you gonna do if you don't get this, if you can't get this tube in? Or what are some backup plans that you have? So that should be something talked about. The other thing that I really feel like we should talk about is bronchospasm. And this year, for some reason, RSV kids are really having more bronchospasms. And I remember, this happened to me a few years ago. It was this little, and usually it's the little babies, and that's what we're seeing right now. The 5-week-old bronchiolitic, good hell, it killed us yesterday. Bronchospasms, my experience with it was horrible. So I was at a facility intubating a little 6-week-old baby. I saw it go through the cords. I never moved his chest. And my end tidal, I did not get, it didn't turn yellow. I got no confirmation. So what does a bronchospasm do? Like a lot of times just having the tube go through the cords is what triggers it. And you can't, it happens in the OR, right? But no one really talks about it. And what do? So what's the first thing you do? You can't move the chest. I saw it go through the cords, but I can't move the chest and I have no color change. What do? You pull the tube, and it's so stressful. And hopefully you can bag them back up, but sometimes you can't. So one of the things, I tried several times. I had my newborn partner intubate. She said I saw it go through the cords. I couldn't bag him up. So we actually ended up, luckily we were able to bag that kid up. I transported him with the LMA in place. Took him to the OR. I was sure he had a TE fistula or some congenital problem. No, he had a bronchospasm. It was a huge, like, aha moment for me, an oh shit moment for me, okay? And this year, we're seeing it a lot. And so one of the things that we were talking the other day, I said, I think for me, I mean, what do you do if they have bronchospasm? What are you supposed to do? I mean, you saw it go through the core. I mean, how long do you wait? Their sats are before you pull the tube. How long? I mean, it's real stressful, right? Yeah. You want to pee your pants, you know what I mean? What do? In the OR, what do? So I've talked to anesthesiologists, and so albuterol is the #1 thing. Somebody said a paralytic will help. Well, paralytic is not going to fix this, right? We've paralyzed them already, right? They're paralyzed. That didn't fix it. So epi, right? You can do epi. So sometimes if kids code and they get a dose of epi with it, then sometimes that will relax the bronchospasm and fix it. But it's sub-Q epi that you should use, right? And so albuterol is the thing. And so one of the things that we've talked about, I think when I intubate this year with RSV, I'm gonna have the MDI albuterol right there, ready to go. So should that happen, I'm gonna give a couple puffs, bag it in, and see what happens, right? And now that we use a video laryngoscopy, you see the cord, you see the tube go through the cord, I can have you verify, yeah, the tube is in. So I'll do a couple puffs of the albuterol, and that's what seems to break it. So something to think about. For me, that's what I'm gonna do, because I don't wanna be that yard sale that, you know what I mean? things go south on. So I'm gonna have it ready, because you're not gonna wait. I mean, if that happens to you, you're not gonna say to your partner, oh, get out the albuterol. Do you know how long it takes to get out the albuterol, the MDI, and fix it? You're gonna pull the tube. I mean, it's hard, right? So you don't look like a yard sale, or just something to think about when you're intubating little kids that are little babies. And like I said, this year, for some reason, RSV, they tend to have more bronchospasms. They tend to, in the past, and I've been doing this a really long time, they didn't like to use albuterol on broncholytics. It doesn't work, it's stupid, right? This year, man, break out the albuterol. They're using it a lot. So, something to think about with intubation. That was everything on the list, right?
There's medications
Oh.
and then a backup plan.
Okay. So medications, the other thing I want to bring up just briefly with medications. So RSI, right, and I think the next Airways we were just going to skip over. RSI, we typically will use etomidate, atropine if they're under 5 years old, 2 years old, depends, but at least under 2 for sure, we're going to use atropine, etomidate, and rock, okay? So how long does etomidate last? I mean, what do you guys, do you guys use etomidate? How long does it last?
Under 30.
Minutes.
Oh.
Minutes,
Yeah, okay.
like probably under 5.
Okay.
So what happened, you've paralyzed them for 20 minutes, you've sedated them for maybe 3 to 5. And I think 5 is, I don't know the exact, look it up, but it's minutes, okay? So we have to review these all the time because like your intubate and stuff's going on. So I typically drop fentanyl and Versed when I do it. So after they're intubated, I'll say, and I try to make my partner know, make sure we don't forget to give these. They're drawn up, ready to go, but let's make sure that they're comfortable after we sedate them, okay? Have you guys ever seen rigid chest with fentanyl on little kids?
I do sedations on the side, so.
There's
I have
nothing
seen that.
more terrifying, is there?
Oh, no.
Nothing. You want to truly soil yourself. So let's just say, and sometimes in the good old days, we just used to intubate the little ones. We didn't give them a paralytic, so we just give them sedation. And so if you push fentanyl too fast, and it seems that, in my opinion, maybe you'll correct me if I'm wrong, little kids, little babies, like you give them fentanyl and they get rigid chest if you give it too fast. And so, great story. I have great stories. So we had one of our pediatric nurses had to fly out to the airport. Another non-pediatric team brought a patient in that was intubated, and they had given a dose of fentanyl to, and all of a sudden they couldn't move the chest. So you're in the back of an aircraft. They were coming fixed wing, so they assumed that they had a pneumothorax. So they started needling the chest. Every needle that they had, every angio that they had in their baggage, I can't remember, was it 20 some? All I know is Laura McBride said when they opened the aircraft and I looked at the kid, they had pulled the tube and were doing mouth to mouth. Blood, the tube is hanging, and there's 20 angiocaths of all different colors hanging out of this kid's chest. Okay. And that was rigid chest, okay? Had they just given a paralytic, they'd have been okay. So it's really terrifying, really terrifying. So if you give fentanyl and you immediately have problems, follow it immediately with a dose of paralytic. So. Okay, let's go ahead on. I think I've covered a lot of these other things. So this,
And it'll probably take that long to go through the sheet, and then you can intubate a half hour later.
No,
It'll go fast.
it should go pretty fast, right? Just a minute or two. Real fast,
But it's worth that time out.
And it was interesting, when we first initiated it, every time there was something we forgot, like we had forgotten to cut the tube. Or we had suction set up, but we didn't have the yonkers or a suction catheter connected. Just it catches you so that, this is a pretty high stakes procedure, right? And you want it to go as smooth as possible. And so it makes sense that you would have a timeout. It just totally makes sense. The fact that we don't have a timeout routinely seems odd. And I think eventually, I would think the medical field will get there, but anyway, we got there. We had a lot of pushback. Not everyone loves it, but it does save you. And I feel like it also instills a little bit of sense of confidence, right? Everybody's on board. We're all on the same page, and we're all in this together, okay? So I think it's very helpful. So this is our goal, right? When you're intubating somebody, whether it's adult or a kid. So you want to have rapid control of the airway, no hypoxia, no aspiration, stable hemodynamics, and then a decrease in the intracranial pressure if you have a head injury child. Okay, so we're gonna just talk and have fun. This is really fun. So these are real case scenarios, And I would say 90% of them happened to me. So I can tell you all about them, okay? So this was a little 2-year-old. This is a long time ago, so you won't know the story, or, you know, a long time ago. I was just in the PICU, and so I was a PICU charge nurse, and we went down to all the trauma ones that came through the ER. And as ER people, you can imagine how unhappy you would be to have the PICU charge nurse come down to help you with your traumas. You wouldn't love me, right? You wouldn't love me. So I came down, not feeling loved. They made me come down. It was kind of hard. It was a hard place to find. And this was right after we started doing it, okay? Needless to say, we still do this, okay? Still how it works at primary children's is what it is. So this was a 2-year-old. Lifeline brought him in. He was alert and agitated and screaming. He just wanted his mom. He had tire marks over his left shoulder. He was missing a tooth, had some blood coming out of his mouth. And those are his vital signs. So you have a heart rate of 188. He's crying, screaming, like screaming, I want my mom. Beyond agitated, right? He hurts. And that's his blood pressure. And that blood pressure was something that they had when they came in. So this is the blood pressure they gave us. And so they throw him over onto the trauma bay. What do you think about his vitals?
Not good.
I mean, he's screaming his head off, right? So sort of a soft blood pressure, low, that's a low. If you look at your numbers, just a low blood pressure. But I think everybody, it was one of those times, right? Everybody's just like, looks okay, right? Look at him, he looks fine. And so immediately it was called as a trauma 1, and sort of everybody kind of went away. Like, he looks fine, right? And so putting the monitors on, I couldn't get the blood pressure to ever read. And so I actually did a manual blood pressure, and it was really amazing. I can still remember, you know, there's certain things when you've gone through them that you'll never forget. This hands down is probably one of my worst experiences, and it was not a flight experience. I can still remember looking at this little 2-year-old who's screaming, ballistic, they're holding him down, and you could watch his perfusion deteriorate. You could see the mottledness get worse in front of your eyes, and I couldn't get a blood pressure. So I finally got a blood pressure, and his blood pressure was 60 over palp. And I was like, oh! And so the ER doc never came and touched him, really, because he stood at the door and looked, he looks okay, right? And it was, you know, you have to get to the scanner, right? It's all about what's your time to the scanner. Get your ass. I said, he doesn't look good. He's like, start blood, appease me. Like, and I'm in an environment, I don't know these people, right? They sort of know who I am, but I don't know any of them. So he said, start the blood. So we started the blood, and we went to the scanner. And in the meantime, everyone's gone, right? So I have this ER doctor who has not really touched the kid, right? He kind of stood back, ran the situation, right? You're the leader, which, right? But I don't think he listened to me. And I'm like, look at his perfusion. And they had gotten a blood gas, a venous blood gas, and I never saw it. Hindsight, right? They handed it to him, and the kid had a venous PO2 of like 12, okay? But it's a venous gas. Does that mean anything, right? Where y'all blow that out. And he's fine, he's pissed off. And I still remember looking at him, and I said, you are not getting this kid in the scanner. Like, he's pissed. Like, I don't know what you want to do about this. Like, you couldn't even hold him down. And he's like, well, give him a dose of morphine. So I gave him a dose of morphine. And I will never forget, like I said, in the room, you had one ER nurse, my tech, and me, and my upstanding ER doc that I would never, I will never like. Okay, I'm an elephant, I never forget, never like him. And the pulmonary edema, that came out of his mouth was like projectile vomit, like, and he just arrested like that, just like that. So this is what I mean. They compensate, and then they don't, right? So that little dude, when that tire had gone over him, I think that's, go to the next screen, it's a different one. Yeah, so you can go back. So his heart was full, popped a hole in his left ventricle. He had a hole this size in his left ventricle, okay? So the only way we got him intubated was, they called anesthesia. Anesthesia couldn't get it. I've never seen pulmonary edema like that. They put a Foley catheter in his esophagus, inflated it, and did a blind intubation. That was the only way we could get him intubated. Got him back briefly, never got him out of the scanner. He arrested and died. Okay, so when I talk about kids compensate, could we have avoided that? Maybe. Like, if they would have recognized how shocky he was, maybe we could have, do you mean, maybe the chest film, could we go back? Yeah. I mean, it's easy to Monday morning quarterback. And you guys all, I mean, they Monday morning quarterback us till the cows come home, right? We have to review things. Why did you do that? Why did you know what I mean? I don't know that would have saved him. I mean, they would have had to crack his chest in the ER. They're not gonna, he's crying. You know what I mean? I don't know that anything would have changed his outcome. But it just, to me, is this huge take home, and I want you guys to feel the take home. Put your hands on the kids, assess them, and if you don't have pulses, make sure people are, like, make them come look, you know, if the docs, you know, then make them come look and check this out. Like, this is really not okay, okay? Really not okay. And so, like I said, I start with that sort of story to empower all of you guys. Please put your hands on the kids and assess them. The other thing I didn't really talk about I wanted to talk about when we talked about vital signs was a liver edge. How many of you guys ever check a liver edge on a kid? Nice job. Are you a NP? Huh? So tell me, I'm Lori. Tell me your name and where you work.
Should be.
And you work in the ER? So liver edge to me is a vital sign, okay? It tells you a whole lot. It tells you fluid status, heart function. Do you know what I mean? It tells you a lot. And I never checked a liver edge on that kid, and it probably was too immediate to see a huge difference. So I don't think I would have seen anything. But liver edge will tell you a lot. And so I really challenge in how you check a liver edge if you don't know. So I like them to be kind of flat, maybe a little bit elevated, laying down. You can't, if they're crying and screaming, you can't get a liver edge. I would have never been able to even check one on him. But I usually start from the bottom of their pelvic bone and just kind of fill up, and you'll feel a liver edge. So their liver edge should be at the right costal margin. And if it's below that, it depends on how far below, you know what I mean? What does it mean? So let's just say you've given a kid 60 per kilo. When you check their liver initially, you know, they look a little septic. You didn't fill a liver, and now their liver's down 3 or 4 centimeters. The tank's full, right? You're filling the tank. If you still don't have a blood pressure, more fluid probably is not gonna fix them. You probably need to start pressors. You know what I mean? So it kind of is like a CVP without a CVP. It's a cool thing. And I'm gonna tell you one more story of how important it is, and this is not about trauma, this is just about kids. I went on a 2-year-old kid that was billed as being renal failure. And I still remember telling my partner, I said, this is weird, 2-year-olds do not have renal failure, something is going on. So I get there, and this little kid has a little flaring, little intercostal retractions, on a little oxygen, kind of lethargic, probably obviously fluid overload, right, for kidneys, aren't we? She's not peeing, she's probably a little fluid overload. So I kind of do a quick assessment. She's got some crackles. I check a liver edge. Her liver was in her pelvis. So her liver edge was down like 7 centimeters. I was like, and I said to the doc, has it been down this low? Well, no. So immediately, what do you think, guys? Fluid overload? Just regular fluid overload because you're not peeing, you think, though?
Well, I think of CHF.
Yes, right? Yeah. So this kid had a viral cardiomyopathy, and we're in the middle of viral season, guys. Check a liver edge. So this kid had a viral cardiomyopathy. And so the reason our kidneys aren't working is because we weren't perfusing our kidneys, right? So her kidney failure was secondary to her heart failure. Okay, these are the kids when I go to intubate that arrest and die. So if you haven't checked a liver edge on a kid like that and I give them RSI meds, I've killed them. I've killed them. Do you know what I mean? And a lot of times you don't get them back. They arrest when you intubate and you don't get them back. Okay, so checking a liver edge is as important as your heart rate, in my opinion. Okay, this is Lori, per Lori, but it will save you. It could save you. So I remember telling the doc, so I called back to primary. I'm like, this is big. And so they said, well, give him another fluid challenge and see what happens. So I gave another 10 per kilo. I put on the pump slowly. And if the fluid challenge works, right, your heart rate drops, your blood pressure goes up, and we're all happy. So her heart rate went up, her blood pressure went down, and I stopped it. And so I started pressors. The kid was on ECMO within 15 hours of being at the hospital, and she was listed for a heart transplant, never got it. She died, waiting for a heart. Okay, so check a liver edge. So that's my way of telling you, please check a liver edge. All right, next one. This is a kind of this was not me, thank goodness. I think I might have had to change my pants after this scene call. This was an 11-year-old who was riding his bike down the street, and some neighbor had made homemade fireworks, and the fireworks went off and hit this kid on his bike across the street, and there he is. So we were called to the scene. He had, it hit him in the hip, and the thing that was most impressive is that he had bowels hanging out everywhere. So when they got to the scene, so you have this huge hip injury, right? The intestines are spilling out, bleeding everywhere. You have a heart rate of 190, barely have a blood pressure, and you have a respiratory rate. So what do you do? So nowadays we travel with blood, right? So you hope like hell that when you lifted on that scene, you took blood. We didn't have blood back then. So it's about it was in the Lehigh area, so probably a 10 to 15 minute flight. What are you gonna do? Okay, so let's talk about this. So, and I'll tell you what they did first. How should I tell you that? So, and I learned a lot from this too. So, the kid would have probably bled out and never made it to the hospital, but they put a pelvic binder on. So we actually have cool pelvic binders nowadays. Back in the day, they used a sheet, and that's what tamponaded the blood from bleeding out. Okay, so they just did a pelvic binder, and they just put that on, and they went. They didn't intubate. They didn't. So what's going to fix this kid? Is an Airway going to fix this kid? You need a surgeon. The only way this kid is going to survive is with a surgeon, right? And what if you give fluid? Is fluid the right answer? No. If you give fluid, you dilute their blood, you dilute their clotting factors, and you increase their blood pressure so they bleed more.
Yeah.
So this is one of those situations, and I feel like with kids, right, fluid's always the right answer. This is one of those situations. If they're bleeding and you have that much blood, the only answer is whole blood. Do you know what I mean? The only answer is blood. Okay, and a surgeon that's gonna fix that kid. So that kid actually did pretty well. I'd often love to know, like long-term, what happens to some of these, So he was in the ICU for a while. He actually did have an ECMO run with sepsis, like 2 weeks after. And they saved his leg, but I don't know how well it works. And, I don't know how, but did pretty well. Any questions about blood and bleeding and trauma stuff? TXA, do we use it in kids? Yeah, it's not like a common thing like with adults. You don't have the standing order to give it, but definitely something to think about. Okay. So this is a 6-year-old that was involved in a motor vehicle accident. And so on scene, the kid's moaning but not responsive. They have a big head lack. They note some flexion with painful stimulus. So flexion, what do we know that is? So if you're flexing with stimulus, you're posturing, right? So decortica, right? So posturing, so pretty significant head injury. And any of you guys worked in the ICU and dealt with ICP bolts and stuff like that? So we treat an ICP above 20, right? So when you're looking at this kid on the ground, you have to assume that they have some sort of increased pressure in their head. And so that should kind of go through your mind. If you don't have a normal exam, unless you have a ton of bleeding out of your ear and you're immediately decompressing so you have some period of time, they have high pressure in their head. So that should be going through your head. So what do you think about the vital signs? The heart rate, 88, respiratory 10, and that blood pressure. What do you think about that?
That's Cushing's triad.
Yeah, that ain't good. So Dr. Carey said Cushing's triad. So Cushing's triad, what is that? Bradycardia, apnea. So this is kind of just on the verge of it, and hypertension, right? So what happens a lot of times when you have a head injury, right? Immediately we have this high blood pressure. Should you treat that? No, you should never treat it. Think about it. Why do you have high blood pressure if you're trying to perfuse their brain? Okay, so if they don't ever treat high blood pressure, in a situation like this, right? You can treat other things, and maybe pain is something you could treat down the road, and maybe that will help it. But typically, it's their body trying to perfuse their brain so they don't herniate. So not the right answer necessarily. So first thing, what are you gonna do about that? What's the first thing you should think about? Just right on scene. I'm thinking about like my job. Like you go on that scene, what's the first thing you should probably do?
Well, intubate and hyperventilate.
Manage the airway, right? So a respiratory rate of 10, is that okay? No. And that kid should have a much higher heart rate, right? They have pain. That heart rate of 88 is, well, it's probably like, it might be in the normalish, low normal for a 6-year-old. It's not low normal for a 6-year-old who just got in a car accident and is hurt, right? So think about that. So the number one thing you want to do is you want to start bagging that patient, fix their CO2. The other thing that I wish everybody could go hang out and do is hang out in the ICU and see what CO2 does to the pressures in your brain. It's phenomenal, right? Take home stuff that you will never forget. It makes a difference, a ton of difference, just the CO2 of 35 versus 40, okay? Huge difference. I'm gonna go to the next one. So some things to do, and like I said, the number one thing, we can't change the fact that the kid was in the car accident, so we need to optimize our care in this little bit of time, right? So there's a lot of stuff you have to do. So you definitely want to prevent hypoxia, so you're gonna bag them, give them oxygen. Who cares if their sats are 100, right? We're not gonna, just put them on oxygen. Bag them, and monitor CO2 if you can, right? So, we used to bag them down to like CO2s of, I'll be honest, I'm old, 20. You know, and their ICPs would be fixed, but we found that their outcome was not any better. So I really feel like you need to be Nazi about keeping your CO2 of 35. If your CO2 is 38, I'd still go up on a breath rate. I want a 35, right? I'm gonna do the best I can. And if it's 34, I'm okay with that, right? So you wanna shoot for 35. Elevate their head of bed, right? That's pretty important. Gravity does help a little bit. What else did I want to talk about? So let's talk about blood pressure and CPP. So that's not really on there, right? So what is cerebral perfusion pressure? So that's the blood pressure you need to perfuse the brain, okay? So I think the adult world, they have higher blood pressures than we do, right? And so I think they shoot for a 60 CPP. And how do you calculate a CPP?
Isn't it your MAP minus your ICP?
Yeah, so it's your mean blood pressure minus your ICP. So you don't have an ICP in the ER. I don't have an ICP. But you have to assume that it's high, right? I'm assuming it's close to 20 at least, right? It's at least. So you have to assume a high blood pressure or a high ICP when they're not normal. And so if your blood pressure is soft, so we want a CPP of 50 is what we shoot for, okay, in the pediatric world. So if you have a soft blood pressure, let's say you have a mean of 60. Do you mean on the 6-year-old you have a soft blood pressure? And you have to assume that their ICP's high, right? They ain't right. Is that okay? No. So what do you do about that? You have a low blood pressure, you know? And as long as they're not bleeding a ton, you give them some fluid, right? Give them some fluid and treat their blood pressure. And you're probably gonna go to pressors sooner than later on something like this, okay? But you wanna try and treat a pressure so that you perfuse their brain. So 3%, we use 3%, and you shouldn't wait on that, right? 3% will fix everything. So it's an osmotic diuretic, and it also improves your vascular. So you give 3%, it's gonna pull fluid in, so it's gonna improve, theoretically improve your blood pressure too even, you know what I mean? Give them more, you're giving them fluid with a small amount of fluid and helping their ICP pressures. So 3% should be something, and we can still use mannitol, but 3% is that one thing that everybody loves. So this is a really cool story. So how long am I supposed to go? Do you know?
It's 3:30.
Okay, I started a little late, so
Yeah.
give me a minute.
You're good.
Okay, so this is a really cool story. This happened a couple years ago to me. I went to Logan, 4-year-old. She fell from a swing set, and her parents brought her in to your ER, and she's been vomiting like crazy. She's fairly unresponsive, and she's incontinent of stool, and she fell from her swing. So, you know, you kind of like your red flags go up. Is this an NAT? This seems weird, you know. So they scanned her, and she kind of sort of came around and was doing a little bit better. And her stents, she had a subarachnoid hemorrhage with some air in her lungs, air opacity throughout her lungs. She was doing a little bit better, and they called me to transport her. So I still remember getting to the bedside. I think you can go ahead. Yeah. So I still remember getting to the bedside, and she was like working hard to breathe. I'm looking at her like she doesn't look good. And I looked at her x-ray. Her x-ray looked horrible. Well, so what do you sort of assume? So I assumed she aspirated when she vomited. And so she has this aspiration pneumonia going on. That was my assumption. Because her x-ray wasn't normal. You know what I mean? She had all this stuff on her x-ray, you know what I mean? And so I assumed she had an aspiration event when she vomited coming in. But she wasn't breathing good. Her blood pressure was soft when I rechecked it. And she just didn't look good. Like, look at her respiratory rate. So that's what I got, you know what I mean? Her heart rate, blood pressure soft, she's breathing fast. She's stating okay because I'm giving her lots of oxygen. GCS was 12. She has a cap refill of 4 to 5 seconds, which is not okay. And so that was her gas that they had gotten before I got there. So she had a pH of 7.2, CO2 is fine, PO2 38, and a negative 12. And she'd gotten 20 cc's per kilo after that. And so I looked at that, and I'm like, well, she maybe needs a little more volume, and I'm gonna give her antibiotics because she maybe had an aspiration event with this vomiting. That was what I thought. So I start pushing fluid and go to load her little butt in the helicopter. And so the repeat gas I got right before I did that was 739, 35, still has the base steps at a 5, and her lactate's 3.4 essentially. So I loaded with phos because she has blood in her head. treated with the antibiotics, and I was gonna give another 20 per kilo. And as we were walking out, you know, you see your blood pressure dropped, and that was in the air actually when she did that. So as I started walking out of the hospital, I'm pushing fluid and we're loading up. And then I get this blood pressure once I load her in the aircraft of 54 over. I'm like, crap, like, you check it again because you don't want to believe that, right? And so I still remember my partner like, do you want to check a gas and see what her crit is? And I'm like, I don't have blood. Like, it doesn't matter what her crit is. Let's just start mixing up an epi-drip. So I mixed up an epi-drip. Her blood pressure got worse than that. We started epi. By the time I landed, I was on 0.3 of epi to get a decent blood pressure. And then she had this period of time that she dropped her sats. So she just dropped her sats and was agitated, air hungry, pulling off her mask. So I went from this little nasal cannula to a non-rebreather that she wouldn't leave on. And eventually I just used my anesthesia bag, dialed the Peep to 10. I couldn't get the sats to read, they were low. And I mean, your choice of that or intubate this kid who's fairly unstable. So I tried that first, hoping it would work, and it worked. So I was able to just maintain some CPAP of 10. She could breathe with the anesthesia bag. So I showed up with good sats. I showed up with blood pressure. Obviously she got intubated, and they looked at me like, why didn't you intubate her before we came, right? I was like, oh my gosh, this was horrible. So anyway, so dropped her off, and I think you can go ahead. And so she had, and this is something, I've been doing this a really, really long time. I've never seen it. I worked in, a long time. They call it a Tacky Syllable cardiomyopathy, and they see it more in adults, and it's usually associated with the Subarachnoid Hemorrhage, right? Never seen it. Been doing it a long time and never seen it. The scariest thing, she had a dilated cardiomyopathy, and so they think that the underlying physiology there is a little bit unclear, but just with this, head injury, they get this released surge of catecholamines that has a toxic effect on the myocardium. So kind of interesting. They talked ECMO even on her. She didn't need ECMO. She did really pretty well. Kind of turned around in a few days. But like something to think about. And it just goes back to like your assessment skills. Like I recognize that she was in respiratory distress, and I recognize her perfusion sucked, but it's just one of those things. Like be ready and ready to go. Like hindsight, I think if I would have intubated her in the ER, she would have probably arrested and died. And they'd have said, why the hell did you do that? So I got lucky and things went okay, but pure luck, right? Well, anyway, very interesting case. Let's go ahead.
Wants to restart.
It does?
I lost my mouse.
Oh, that's just a cool picture. This is a kid that fell. I told you falls are a big reason for injury. Knitting needles, because it's a wand from Harry Potter. To the back of the picture. Did you see that picture?
Well,
It's
I'm
not
trying to
good.
go back. Yeah, there you go.
So that's her flying the helicopter. She loved the helicopter. She wanted to go visit it a lot. So she had to go to the OR to have that taken out. That's just a cool picture to make sure you're awake. So NATs, I'm gonna just briefly talk about NATs. It's one of those things that you sort of have to talk about, non-accidental trauma. It happens probably more than we think. But then I also feel like if you look at those pictures, like one of those is my daughter who got a cleat to the eye and just has one block eye. And the one little kid has ITP, which is idiopathic thrombocytopenia, right? So they look like they've been beat up, but they haven't. And so it's a hard part of our job, right? We have to treat people nice. Even when you assume that they probably beat up their kid, and it's hard. It's a hard place to find yourself. You can just go ahead, Jen. So some classic signs, right? The story's inconsistent. You fell off the couch and you have a broken rib, like we talked about, stuff like that. Oh, you went too fast. So they delay seeking help. So instead of calling 911, these are the kids that they show up in your ER and they hand them to you, right? Because they didn't want to call 911 to come to your house. So typically those are kids that or they wait for a while for them to do better before they call 911. Boyfriend is always a classic, right? Somebody that's not a biological parent that's caring for him. And just the thing that I find that's most consistent is the stories change. So it's really, really important, I feel like, to try to stay, like, we're taking care of the kid, that's what our job is. And just document the stories and how they change, because that's helpful down the road. But it happens to anybody. Like, I was talking to, I have a couple daughters who are nurses, like I don't think people, when they're shaking their babies, realize how bad they can hurt them. I don't think, they're not hitting them, and I think they're frustrated, and I don't think they realize, do you know what I mean, that shaking a baby can hurt them that bad. And so, but what it all comes down to is you have to still prevent secondary injury. Document stories, that's our biggest job. The one I'll never forget as long as I live is this little dude who had been through the ER, and I'm not here to lecture on NITs, Jimmy, we could talk about this for hours, right? But this little kid came in, had been in our ER at Primary Children's, which I think primary is the first one. Like, you show up with a broken arm and they're checking things out, right? They're looking behind their ears. I mean, they're checking to make sure there's not another sign that maybe. So he was in our ER and had a cast, and 3 days later came in with a head injury, fixed and dilated, and died. Right? So it happens. It happens all the time. So some things, and they'll talk to you about, there's certain injuries. I've just been to a lecture not that long ago. Frenulum injuries, any ear bruising is considered I can't remember what they call it. It's like a sentinel injury. I think it's a sentinel injury, is that what they call it? I want to say it's a sentinel injury. That if that happens, then they tend to do more like bone scans, chest films, and follow up a little bit more. If you come in and you have those kind of things, it's considered suspicious. And actually, because you can't scan everybody, right? You can't scan everybody that shows up. But if you scan the ones that have these sentinel injuries, the percentage of other injuries you find is high. So, something to think about. So I want to talk a little bit about PEEP and drowning injuries. So, first of all, I have a question for you. What is pulmonary edema? What does it look like? It doesn't matter if you've drowned or if you had a full arrest. Like I told you about my kid that was coming through that had all that vomit. And so it's that pink frothy blood. So how do you get rid of it?
Tamponade.
I didn't hear you. Peep? Peep? Anybody want a suction? There's a part of me, good answer. There is a part of me that thinks it's disgusting and would like to. And I'm going to give you an analogy because while you guys might not, I guarantee you, even in your ER department, somebody wants to do it, okay? So I'm going to give you an analogy that you will never forget. And another story. So if I was cutting down my Christmas tree and I whacked my arm with a chainsaw and I have a spurter, what are you going to do for me?
Pressure.
You're going to put pressure on it. If you came at me or if I came at you with a suction catheter and you had that, you would think I was a dumbass. So you think about that. If you have bleeding from their lungs, they're bleeding, and you suction them, it's not a good move, right? The only way to put pressure into your lungs is PEEP. That's the only way. And so lungs that are bleeding, pulmonary hemorrhage, pulmonary edema, you have to use PEEP. And even just disconnecting your circuit, and that will happen a lot. You'll disconnect your circuit and the patient totally decompensates, right? Because you've lost their PEEP. And I'm going to show you this really cool little demonstration. So I transported a dude that was like, 15, and he had a pacer, and his pacer malfunctioned, and he had a full arrest at home. And EMS did a great job, transported him, did great CPR. And I remember going to the ER, and it was crazy, right? And whenever I go on a full arrest, I don't set my PEEP at 5. I usually start at 7 or 8 on kids like that, just because you need more pressure. Usually they have pulmonary edema, and you're going to need more than 5 of PEEP. And a drowner, for sure, you're going to need more. But you know what I mean? So usually, if I'm going and they're on a vent, that's where I sort of start if I'm going to set it up. So I had the PEEP set at 7 when I walked into the ER. The kid had no blood pressure. We were mixing up an epi drip. And I had placed him on my ventilator, and he started coughing, and so the RT there, and RTs are smart people, I don't even know. So the RT suctioned him, took him off and suctioned him, right? So it wasn't just like he used the Ballard, right? Disconnected my circuit and suctioned. I was like, oh, I saw him do that. I said, let me turn my PEEP up to 10. So I turned the PEEP up to 10 thinking that was a clue, like, don't do that again, right? Because I have to be nice, I can't be mean, don't write me out. Just don't, I turn the PEEP up to 10, it'll be okay. And he disconnected my circuit 3 times. At one point, there was so much blood in the circuit, I had to change out the sensor. I ended up transporting the kid on 18 of PEEP. He neurologically had a great, totally normal neuro exam, but he needed ECMO, heart-lung bypass, because his lungs were so sick. By the time it looked like arterial blood was coming out of his ET tube by the time I got done. So every time you disconnect, you go back to 0. So let me just show you, this is pretty cool, I can make sure I'm all the way inflated here. So I'm gonna just show you the difference it makes, okay? And I don't sometimes use the most smart words, but I'm gonna show you how cool this is. So this is a PEEP of 5, okay? So I'm gonna use big volumes because it's a big lung. I wouldn't use, and you can just see, Okay, I'm bagging, it looks okay. So I'm gonna show you what a difference that just a little bit more PEEP is gonna make, okay? I'm just gonna go to 10. See, that's when it honks, right? You hear that honk, so it's hard to see if you have it early. So what I want you to notice is, and as you go, as you keep going along, you'll see it'll start to recruit more and more, you know what I mean? And so what happens every time you disconnect, right? The same thing as disconnecting is losing your PEEP, right? So I want you to see, so it stays kind of puffy. The second you totally disconnect, just watch them just down. So, and then it takes more and more pressure to inflate it again, okay? So every time you're starting back over, right? So I'm starting back over and it goes like that. So because he's really dead, I'm gonna just give him a little bit more PEEP. So it's a better visual, okay? So watch, I'm gonna leave these somewhere. His little lung has a hole somewhere.
He's actually there.
He's real dead. But you can go, if you were to keep the PEEP up, then maybe I can get it. That bottom one is where they'll probably hold it. You can see his hole's probably right here. But like I said, a lot of times it'll kind of hold it right there if you don't have a leak. It'll really hold him. And so how can you switch to my ventilator? Because what happens a lot of times, and maybe where you guys have a flight team here, you don't see it as much as you will at other places. But a lot of times when you transition to my ventilator, right, they decompensate, their sats drop, and so what do we want to do? We want to disconnect them and bag them, because that fixes everything, right? And so when you disconnect and bag and you go back to square one, right, then you have to re-recruit and start over. And is there any way to hold the PEEP in? Right. So clamping your tube, and so what that looks like is you'll give a breath, then you'll clamp the tube, change your vent over, and then unclamp the tube and hit start, kind of at the same time. You don't want to give a breath and hold it, and then give another breath. So you want to, exhalation is when you would clamp. So exhalation, clamp, and then hook it up, and ready to go. Did I miss anything? No?
And you said you wouldn't have your vent going, you would wait and push start once you're connected, is that?
Yeah. And the other thing to know about, this is kind of a cool thing that you should think about, is vents. So most vents nowadays are APV, which is adaptive pressure. And so you actually have, if you were to start the ventilator on one of those green lungs, right? So it adapts to that. And so if you start your vent and it's working on that, and you transition it to this sick lung that's half dead, it's gonna take 7 breaths, 7 to 10, to equilibrate to be able to ventilate that lung, okay? So that's why they really decompensate. So you should never, at least with our ventilator, it's best that they equilibrate on this lung that you're putting it on and not that green plastic one. Because otherwise your time frame is worse. And sometimes on somebody who's sort of, when you hook them up and they look really poor, sometimes I'll actually even turn the vent rate up for a minute. You know what I mean? Give them a few more breaths and then I can turn it back down, right? Just to let that ventilator get, adapted to this, right? This is what you need to fix for me. So, okay, questions about PEEP? No? It's your friend, use it wisely. Okay. So I want to just put a quick little bleep in, because I'm going to try, if I'm done by 1:45, is that okay?
Oh, of course.
Okay.
You
So I'm
have
gonna-
3 minutes remaining on this computer before it restarts. Just saying.
Is it not shut?
That's true. Why
So
did
you
you
just
want
said
to-
it needs to restart
Oh.
automatically. I
Maybe
push
delay it.
snooze and it doesn't.
Does it
work.
say delay?
It says snooze, but it doesn't believe me.
Oh. So
Hopefully it's not a long update.
So cold water drowning is one of those times that things can be different. So typically drowning injuries, you should treat them the same as a head injury, right? They have an anoxic brain injury, so all of their brain cells are tight. They have high pressures in their brain. We don't bolt those kids, but we should still treat them the same. You should keep a drowning patient with a CO2 of 35 if you can do it. You want to prevent hypoxia. So similar things as if they had a head injury when they drown, but they're pretty hard to manage when their lungs are really sick. So PEEP is really your friend in that situation. So cold water drownings occasionally, and for you guys down here, you're sort of at a disadvantage. I'm about to talk a little bit about your kid that drowned on Christmas Day a couple years ago. Remember that one? Cool story. But anyway, so what we do up at Salt Lake, and anytime you have a cold water drowning, right, I always tell people this should be a scene flight and you should only go to primaries. So what they'll do at primaries, they call it a trauma 1 op ECMO. So if you have a cold water drowning, if you have, I mean, anything that's cold, they come in with a really cold temperature and they're asystolic. They'll evaluate whether they go on or not, but they put them on ECMO, and it's amazing. We've had some great stories, some great recoveries. So that's just a picture of ECMO cannula. So that's a baby, so right, they cannulate through the neck. Typically on a bigger kid, you're gonna cannulate neck and groin is where they'll cannulate. And it's pretty amazing. So they can actually, and there's great stories, there's great literature, and I'm not gonna prolong this whole thing because I could talk for a whole hour on just cold water drowning because it's a cool thing. But just know that there's some great outcomes when you do that. So when you're cannulated. In the ER, initially I think the first kid that we did that way, it took them 27 minutes to cannulate. I think the most recent is down to 10. So you show up in the ER, CPR progress, and they're cannulated in 10 minutes. Chaos, but cool. Very, very cool. So Christmas Day, you remember this one, 2017, down here? So this was a kid, and you know that's the picture of the pond. He was running across the pond, chased his dog, fell in, right? So this is the perfect scenario, right? Except for you guys don't have ECMO right here to put him on. So luckily they got, so the best case scenario, right, is if you get a heart rate back, right? That's the best case scenario. In Salt Lake, I feel like sometimes we wait a long time to do that, and then they've missed that window of opportunity. But for you guys, you don't have a lot of options. But this kid did really well, right? So he was obviously in cold water, it's full of ice, is a witness. And so how come you do okay is if you're dead and cold or cold and dead. So if you get cold before your heart stops, there's a good chance that neurologically you're gonna be okay. But if you're dead and then you got cold, outcome's not gonna be so good. So what we found is usually the kids declare themselves. We have never saved somebody who was completely vegetative. They either do really well, they declare themselves, and they don't survive. So the ones that do well do really well. Great pictures, great stories, you know what I mean? So it is pretty cool. That kid got heart rate back right away, was taken out. The rescue story is amazing. I mean, everything about that story is cool. It is a cool story. So he went home several days after.
It's restarting.
That's awesome. That's awesome. No, very cool story, that kid. Very, very cool. I actually used to do the ECMO priming when I was in the PICU. And I still remember on New Year's Day, I don't remember how many years ago, this kid, and I think I have it on here, so we'll just go there. We got a call for a trauma 1 op ECMO for a bathtub drowning. And I don't usually at that point I almost always did night shifts, but it was a day shift, and it was a holiday, and I wanted to go home, and it was 5 o'clock at night. And I was pissed. I was like, why are we putting a bathtub drowner on ECMO? Like, nothing about that says cold water. Nothing about that seems like the right thing to do, except for torture Lori, right? That's not happening. And so what I didn't know was the kid had a temperature, a core temperature of, it's on there, I can't remember what it is.
Sign in.
So the core temperature was really cold, I want to say like 26 degrees.
Oh, wow.
So the doctor in the ER obviously watched a lot of CSI. And so he knew, I didn't know this, he knew that your body temperature can only drop by so many points for every hour that you're dead. And so there was no way that this could possibly be even possible. So that's why he called the trauma 1 op ECMO, and we put this kid on. And so, is it gonna go?
You didn't do it right.
I did it.
You put your password in. Hey, just leave it.
I can't do 2 things at once. Anyway, so they called this kid, the kid was 3 years old, and the thing I remember about the whole situation was that she had really bad hair. She was 3 years old and her hair sucked. And that's because I'm right there, right? Getting the cannulas ready, and she had really bad hair. Things you think about, and things you remember, right?
Which one is it?
A 4, maybe?
4.
Oh, yeah.
So we cannulated her, and it's really cool when you see that happen. So you have somebody who is dead, like dead as a doornail, and you are doing CPR, and then they cannulated her, and then we warm them up just like that. And once your temperature gets to a certain point, she kind of went into a little bit of VFib, and then she just got her rate back. We didn't shock her, she just got her heart rate back. And she started taking some agonal breaths, and I'm like, good hell, what did we just do, right? That was my thought. Anyway, I went home, kind of left that at the door, and I came back about 3 days later, and I said, oh, what happened to that kid we threw on ECMO the other day? And in that bed space where we had left her, was this kid that was kind of sitting up in bed and looks pretty good. And they said, that's her. I was like, no! And it was. That was her. So what had happened, she was actually an NAT. And she actually had a cervical injury that she had to wear a collar for a while. So she was a kid that they were putting in ice cold water. They were potty training her, and when she peed the bed, they were putting her in this ice cold bathtub. And her hair, you remember I told you it was all snatched out, or it was bad. So they were pulling her in and out of the tub with her hair, right? And this ice cold water, because she peed the bed or whatever. And so she truly was cold before she was dead, right? So how do you ever know? And so, like I said, it's not my call. My call is to do what I'm told and whatever. But interesting case, right? I would have never put the cold water tub drowner, the bathtub drowner on ECMO, but she did really, really well. So, anyway. Did you know which one it was?
I think she just guessed.
What is it, 19?
So I wanted the end to show you my cool,
We'll make the end slide.
no, I want Spencer. So do you remember which trauma one it is?
Yeah, I've got the,
Oh.
but I just don't know where it's.
Oh, go back. The end.
To the end.
So that's a big, I wanted to show this picture just really quick. Go back one, okay. So this is a kid, a bigger kid that's on ECMO, okay? So ECMO is not some low, I'll go back to my slide.
No, you're good. I'm getting the picture.
So ECMO is a big deal, right? So sometimes when I talk about it, maybe you don't make it seem like a big deal. A lot of kids that are on ECMO, third space, especially when you put them on for trauma, drowning, stuff like that, third space, a ton of fluid. And so you can see how huge this little person is. We open up bellies a lot. Why would we open up bellies? Do you guys use open belly? Do they open bellies here a fair amount?
Not that.
Abdominal compartment syndrome. So some of these really sick patients, really septic, will end up with open bellies. And so that's an open belly. Doesn't look too bad, right? To me, an open belly sounds gross, but it's really, they open it. And so this is how old I am, and I won't tell you an exact age, but we used to give kids fluids, and I remember a sign that you'd have a lot of fluid was when your ears would stick out straight, right? We could make kids swell till they're well like you've never seen. And so, but then they all had multi-system organ failure, right? Their kidneys shut down, their livers shut down, and they were a disaster. So once we started opening up bellies, you don't see that, right? So we open up bellies so that you don't have abdominal compartment, and so you're still perfusing their liver and their kidneys and their guts, and they do so much better. So while it looks a little gruesome, they actually do tons better. So I want to talk a little bit about organ donation, because I know, especially where you guys are so far away, like how many times, and I guarantee all of you when I say this, are going to say, I've thought that before, right? Why did we send that kid? We gave these parents a big bail, and their kid's going to die. So why did we possibly send them, right? I know you've all thought it. I mean, I've personally thought it myself, okay? So I want to show you why we do it, okay? So there's a cool end of it, and nobody wants to ever be on the recipient or, but I just want to show you my friend Spencer. Real cute little dude. He's 5 years old, and he came in the fall. Normal kid, he had a viral cardiomyopathy, okay? So check a liver edge, remember, check a liver edge. He was one of those kids, right? So he actually was from Logan. You can go to the next page. So he came in, severe heart failure, ended up on ECMO, and I don't remember if he was crashed on with CPR or I don't remember that part of it, but his heart function was so poor, he was placed on ECMO. And then we have what they call a VAD. So adult VADs, right? You guys have probably all seen them, right? These people show up with their VAD and they carry a little suitcase and a little purse with them and that. So kids don't have purses VADs. We use the Berlin heart. So if you go ahead, I'll show you what the Berlin looks like. So they transitioned him from ECMO to the Berlin, and you can't see a lot here, so go to the next one. So that's what it looks like up close and personal, right? So he's still on the heart transplant list at this point, and so we're in November. So he got cannulated, and so while that equipment right there goes to that, so that equipment, you can see the drive line coming out down by his groin, goes to the next one, go to the next one. So that's him on Thanksgiving. So he went from dead, he looks pretty good. And so I'm gonna guarantee you that he's gonna do a whole lot better if he gets a heart right now than if he were to get a heart when he was on ECMO or just cannulated with the VAD. So that big machine that you see sitting behind him, that's the Berlin heart. So that's the pneumatics. So everywhere he goes, guess what? Berlin goes. So these kids don't go home. So when he was here, he hung out in the ICU. So this was Thanksgiving. He'd already been there I don't remember when he was admitted, but he'd already been there for quite some time. He went to a special room to have Thanksgiving dinner with his family. I still remember his bedroom for Christmas in the PICU. I could tell you what room it was in, his Christmas tree decorations, and he's hanging out with his Berlin. Nowadays, the kids can go to the floor sometimes while they're waiting for a heart transplant. So you can go to the next one. So the other thing that they work on with him is just physical therapy, right? So here he is riding his bike. You can't see his Berlin, but it is there on the side. Okay, so you're chasing him while he's riding his bike down the hall. Cool story, right? I've seen kids walking down the hall. We had this little black boy that was the cutest thing I'd ever seen on a Berlin, and we were following around down the hall just last year. So we're trying to get him right, best case scenario, like you're gonna get a heart and you're gonna do okay? So he's waiting, and right after Christmas, the first of the year, he did get a heart. Did really well and has done awesome. So every time you guys think that, why are we doing this? There is one of those kids up there sitting with a Berlin heart waiting for a heart transplant. Doesn't mean that your kid's gonna be the one to do it, but you know what I mean? It definitely gives parents some sort of closure. And I feel like whenever you talk about traumas, you sort of have to talk about that, because I do feel like it's something positive that can come out of it. Not every family is gonna wanna donate, and that's okay. I mean, that's totally okay. But it's something, to think about when you're transporting kids out and you're thinking, I don't know why we're doing this. That's why you do it. Think of Spence. Think of Model Spence. So that's all I have, unless you guys have any questions, and I hope that you can go home and say, I learned something from Lauren today, and it was helpful. Any questions, or?
Have you seen a drop in the organ donation because of COVID in kids? I know in
I
adults it's huge.
Really?
Yeah.
I don't know if I have or not. I still feel like that they still donate. They were doing a liver transplant 2 nights ago up there. I feel like still they donate quite a bit. So we do a lot of DCDs, and I don't know if you guys, I think adults do some, but not as much as kids. So DCD is donation after cardiac death. And so what that looks like, so these are kids, let's just say you have a drowning and their neurological outcome is nothing, but they probably are not gonna declare themselves. So they're not gonna declare themselves as brain dead, so they can't donate really. So they have what they call as donation after cardiac death. So they have the OR on standby, so they withdraw from the ventilator, they stop any sort of cardiac meds that are running, we keep them comfortable. And if their heart were to stop in that first hour after we withdraw support, they can be taken to the OR. You obviously can't donate a heart, but you can donate liver and kidneys. And so we do that a fair amount. At one point, and I don't know if we still are, I don't have recent numbers, that we were the #1 in the state for DCD. So, I don't know. So, like I said, it was one of those things, it's hard, I don't know. I don't ever want to be faced with something like that. Hard stuff, right? Hard stuff. But some closure, right? Some closure. And I know just recently we were on a scene, and it was a bad scene. It was a go-kart accident on scene, blood everywhere. I'm amazed. We train to do surgical airways if we need to, right? And on kids, right? We really don't want to. I've often said, if I ever have to do a surgical airway, I'm going to need clean pants when I'm done, because I'm going to be in bad trouble. And so this kid got a surgical, they cracked him on scene and brought him in. He obviously got to be an organ donor. He was really, really bad. And his family, I heard this from several people, couldn't thank the flight team enough. The ER kept saying the family was so appreciative. They had time to say goodbye. They got to donate some organs, and they had closure with the process. You know what I mean? So something that makes me feel better, I guess, because there's times, you know what I mean? Like, why do we do this? glad to do this.
The other thing we've seen here several times is kids that are suicide that have isolated injury that, you know, they're probably not gonna survive. We still have EMS bring them in a lot, and the two things is, one, to donate, but the other thing is they don't die in their parents' home. And their parents have that closure that they didn't die in my home and they got every chance.
Yeah.
So it helps the family process.
And I'm, like I said, I don't think there's a right or wrong answer from the flight perspective on scene. So on scene, and we're all different, like I said, it's, what I do is not right for everybody else. Cause some people will declare on scene, and I'm like EMS didn't call me to declare them on scene, like they did not call me, they want me to get them out. And so adults will never transport with CPR in progress,
The kids do.
but I do frequently, and mostly I just do, because I feel like primaries is really well equipped to help with that grieving process and to help. They can say everything was done, you know, but there's two sides to it. People will say, well, now they have a flight go, and now I don't know what's right. But for me, EMS called me, and I'm gonna get them out. Like, this is stressful for you, I'm going. And so we might be doing CPR, but this is, and you know, and like I said, if you manage the airway, 95% of the time you will get a heart rate back. 95%. So, and like I said, not for long, it might not last. I mean, they might not even survive more than 12 hours, but you'll get a heart, if you manage their airway right, you will get a heart rate back. So, their hearts are young and strong, and so, anyway. Well, thanks for letting me come hang out with you guys. I feel like my
Thanks for
old normal
doing it.
self.
Thank
So, but I used to teach all the time, and COVID happened, and I went away. So, they wouldn't even let me go anywhere. People would ask, and I have to ask permission, can I go teach? And they're like, no, you're not doing that. Okay.
Thank you, that was awesome.
Thank you.
That's great.
Well, it's so nice to meet you guys, and it's been awesome.